On the table, we have, you are in Copenhagen. It's a Copenhagen team. My name is Gintas Bielauskas. We have an excellent team of fellows and nurses. The patient, who is a female, 83 or 82, yeah, she is 83, with atrial fibrillation, severe aortic stenosis, and no other major comorbidity except for moderately reduced renal function. Okay, we were also trying to show some screenshots here, which are from CT planning, which we were using to judge the size of the valve, of the anatomy, the calcification, the angles, which we will use to deploy the valve. You can see on the top row here, this is annulus and LVOT measurements. They are big, in the range of 90-94 for perimeter. We have sufficient size of sinotubular junction, around 29, sinusoidal salva, on average more than 34. We have sufficient height of both coronaries, so we don't expect any coronary issues. We have severe calcification of aortic valve, as shown in this middle panel here. We have calculated angulations from which we will deploy the valve. We have selected Evolut 34 as a valve for this large anatomy. We could have also selected Sapien. We have that on the shelf as well. Both would fit, but in this case, we will use Evolut. We also, of course, always judge anatomy or look at the iliacs and aortic arch, whether or not we will cross it difficult or easy. So this aortic arch should hopefully be feasible. It's a little bit acute, but not too acute. We hope not too calcified. We hope the device will traverse it pretty easily. We also will attempt to use a sentinel due to the severely calcified valve. We know there's some controversy and evidence, but we tend to select patients, selectively use that sentinel device, not in all our cases, but in some of them. And severely calcified valve, bicuspid anatomy, valve in valve, those would be among the potential indications. So this we qualify as severely calcified aortic valve with a big calcium burden, and that's the reason we will try to use it. Anatomy seems favorable, so we incline to use it. That's our plan. Now, behind my back, my colleague Ronnie, he is already, I can see, accessed the right radial and contralateral vein and artery. So while Ronnie is going to continue for the main access, we do it ultrasound guided. I will scrub in myself and will join you by the table in just a couple of minutes. Meanwhile, Ronnie, you can, if your microphone is working, you can also tell what you do. And as of right now, Ronnie is set already. We have right radial access, and we have also the access on the left side in the femoral vein and left common femoral artery. And now our next step will be a single prostyle, which is on its way into the patient body. Now here it's important not to kink a wire or anything. Like if the patient would have a bigger distance from the skin surface to the artery, you should actually use a long wire for this. Here we use just a short one because BMI is normal, as I mentioned before. So we don't foresee any problem. We have to have a nice back bleed from the prostyle to be sure that we are sufficiently in. As you see on the fluoroscopy screen, the wire sticks a bit out from the longer sheet left femoral vein. And this wire we will use to deliver pacing, because one option is to pace, as we know, on the RV. Another option is to pace on the LV wire, but then you need a second source, a second contact, which is either at the skin level or it can also easily be a wire inside the patient. So we'll use that in this particular case, the wire. And in the fluoroscopy screen, we'll immediately see the retainer tabs are perfectly loaded. They are nicely caught in the good position. There's no infalls, there's no struts that would be kinked or bent. So it's a very good load. And our next step will be to flush the radial and to deliver the sentinel device. Heparin is given. Confirmed, yes, heparin is given, so we should be all good. So sentinel device is a filter-based device to protect against embolization. And it's delivered on the PCI wire, the BMW wire that you're seeing, which is finding its way down to the ascending aorta. Let's double check that it's ascending aorta. It should be ascending aorta. Yeah, indeed, that's fine. Like the AL1, which we have currently, for me appears to be slightly too curvy. We need a bit of a bigger curve, like less direction towards the left main and more direction towards the non. Let's take AL2 because I think that should hopefully give us a more beneficial shape. So we keep the wire, keep the wire, and we take AL2 catheter just for hopefully better shape of it. Yeah. And then we'll try to see again. How does that do? I go back to cusp overlap projection here. And I think if we would still have struggle here, we might take Terumo wire as our next wire. So now we're approaching with AL2. We'll see if we have any better luck with that one. Yeah, so this one is certainly more vertically positioned. Let's see if this allows us to steer it better. Yeah, the chunky non-coronary cusp that can do even the short cine here. Do not enable, like just to show you. So on the screen you can see this chunky non-coronary cusp. It's almost on top of the other cusp, kind of preventing the wire to slip in. I hope we will still find its way. Because there should be a commissure next to it somewhere. It's not just one spot. Let's hope that we will find its way. If this wire struggles, there we go. Well, that would be the place, but it just doesn't want to cross it. Now, before I attempt any further steps, let me also check once from LAO. How does it look like? Yeah, here we seem to be good. In LAO, it's much better this time. So it's okay. It's middle of the valve, so we are not in any kind of a strange angle. We're in a good angle. I think we probably need to ask for a Terumo wire here too, because it's probably, let's take a Terumo wire, because I hope it looks like the shape of the bulky shape of the leaflet is kind of preventing the regular wire from easily crossing it, even though we seem to have a good direction, but still it doesn't want to go through. So now we have a Terumo wire, which is a bit more slippery wire. It may shoot forward, but I'm slowly trying to use some rotational maneuvers to get that catheter very carefully inside. It's a high gradient we can see on our hemodynamic screen. Peak gradient 60, mean 46. We have end diastolic pressure in the ventricle 17 and diastolic in aorta 58, 1758. We will remember those numbers to compare to the situation after the valve is delivered. And we will do rapid pacing with maximum output, frequency 180. So are we ready there? Pace on. So we have good capture. Balloon up and balloon down and pace off. Observe for AV block. Flora safe. Okay, good. She is in the same rhythm. We walk carefully our balloon out. I can zoom out here, wait a minute, like this. We will preserve this balloon because we may need it to be used by the end of the procedure to post-dilate as well. So we will flush it and wash it. Come to the valve. So now we get the valve, and you will see this valve will cross the eye sleeve. So remember, eye sleeve is like 14 French insertion profile. It should match pretty well the even 34 Evolut R. Let's connect some flush here, just reflush just in case. So I will go slightly lower. So we still keep wire in the picture, and we include a little bit of the sheath in the that you can see, you know, how that valve is traversing and crossing inside the sheath. So watch the wire. I'm going forward, and it goes pretty easy actually. You know, it's not, sometimes depending on the specific sheath, you may expect a bit more resistance, but here I basically just use a couple of my fingers actually to push it forward, but sometimes it's much more difficult than that. So here we have like a nice match between the two devices. So we're out of the sheath. I will connect my pressure set here to the inline sheath now. Next thing we'll do, we'll go, Ronnie is already moving the table towards LAO direction, because with Evolut, it is of course important to make sure that we have a marker, so-called head marker, on the outer curve of aortic arch. And to see that, we need to go LAO So this is LAO direction, and we will want to see the head marker on that outer curve. To achieve that, we typically have a flush port of the Evolut valve facing 3 o'clock. Usually that helps, but sometimes you need still to fine-tune it a bit as you come up. So Ronnie is watching the wire, and I believe we see the head marker nicely on the outer curve. Agree? Yeah, so it's nicely on the outer curve at the front end of the valve. Now, remember the arch is a little bit on acute side, not very acute, but a little bit on acute side. So Ronnie will be railing, like pulling back on the wire, maintaining tension in that wire, and we are carefully crossing forward. You see there's no interaction with the Sentinel device in the neck vessels. Sentinel sits nicely inside of those vessels and doesn't interfere with valve crossing. So it's all good here, nice crossing. Flora, save that. Go 140. Keep gentle push on the wire. 160. Now she loses pressure because we're occlusive. I go faster and stop pacing. Stop pacing. Observe for AV block. Let's see. What do we have? No AV block. Actually, she has own rhythm. Do we want to reposition or not? So, well, this is, I think, according to the book, we are like 1 millimeter below the pigtail into the non-coronary side. Play back on the minus. We seem to be in the middle of aorta, kind of. We can expect a little bit of diving on the non-side. And my thoughts were, do we need to go higher? But on the other hand, on the left, we are not very deep there. So even, and the STJ is not very wide, so it should hold the valve and prevent it from deep diving. So probably we will accept. The patient is stable, actually. She's noradrenaline did its job. Its pressure's on 95 or so, systolic. Play back on the minus again, two times. 1 and 2. What was it? LAO 48. So we go to the LAO projection and a bit of a caudal. We will double check from here. I'm leaning towards accepting this. I mean, we can see the patient doesn't tolerate all the manipulations too well. I think we're in a reasonably good position. We could maybe go 1 millimeter higher, and now we risk it may slip a little bit down on the non-side. Otherwise, I'm pretty happy. So let's accept. Let's go down on noradrenaline to 5. And relax the wire now. Relax the wire, and we go for slow deployment. We go for slow deployment, and we're gonna see how that valve does. It's very slow deployment that I'm doing. Relax it like this, yeah. It's very slow deployment that I'm doing. It's important to take your time here, you know, because it usually ensures more stability. So we're almost fully out. There we go. It's released. Let's see if there's good capture. No capture yet. Let's wait. Sometimes it comes just a few seconds later. If not, we will go slightly slower on pace rate. So in that case, yeah, now we have capture. Wait. Okay, go up. Go up all the way like this and down. And pace, and stop pacing. Flora save. Observe for AV block. No AV block. Okay. So we saw the valve frame a little bit expanded. So this balloon did a little bit of additional push on the frame, and actually we cannot do much more. We chose the biggest possible valve. I believe the valve sits very correctly in terms of height, and now we use maximum possible balloon to post dilate. So in case we would still see some remaining PVL, hopefully not, but if there was a case, there's not much else we can do about it. Because we cannot normally take a bigger balloon. There shouldn't be any need for that, but we'll see. So our next step, we're putting pigtail into the LV. We will first do hemodynamic assessment, and then we'll do angiography. Then we'll see what those things, what information do we get out of it. So pigtail, it comes down. Yeah, wire back. So we'll do first hemodynamic assessment here. So we have one pigtail sitting in LV, the other pigtail sitting in the ascending aorta. And we're going to see what We're going to see what pressures can we measure in those places. So pressures are on the screen. So gradient is 0. There's no gradient that's obvious from what we see. Our previous pressures were 17 in LV, 58 in aorta. We have 24 in LV, 50 in aorta. So the separation is slightly smaller than it was before the TAVI. Gradient is only 2 millimeters invasively, so there's no gradient. Except that, oh yeah. So we see a little bit of leak next to the valve. That could actually be also partially due to the fact that anatomy is really large. This was the upper limit for everything, including Evolut valve. That was, we measured perimeters approaching 94. So in that case, of course, it could also be close to the limit of what the valve can cover. Otherwise, the position of the valve is really as it should be. It's in relation to the left bottom of the left cusp. I think we may be 3 millimeters below the annulus or so. In relation to the right cusp, we are the non-coronary cusp. We're just 1 or 2, so it's symmetrical. It's not too deep. It's not too high. I think we will accept this result at the moment because additional things that one could consider. If the leak is too much, it would probably be a valve-in-valve to extend the seal higher up, but that should only be considered if the leak is really giving symptoms and more than moderate in severity, or at least moderate in severity and giving symptoms. Here, at this very moment, I would qualify this as a mild leak. You could discuss mild plus, like between mild and moderate. It's a bit more than we typically want to see, to be honest. But again, you typically can ask yourself 3 questions each time you see a leak. Is the valve size correctly chosen? So this is the biggest model we could choose, Evolut 34. Then is the valve position correct? And looking at these angios, I don't think you can do a better position. It's exactly how it should be positioned, 1 to 3 millimeters below the annulus, depending on which cusp we look at. And then the third question is, did we use a biggest possible balloon? So we used a 24 balloon, is that correct? That was a 24 balloon, which gave some expansion and then some recoil. So in this situation, I think we will accept this leak at the moment. We will follow the patient clinically, and only if she has a problem, we will then consider something additional. She is 83, so normally longevity-wise, this should not have any impact. And if she doesn't have any symptoms of it, then we will be happy. If she has symptoms, we will bring her back and do some additional things with the valve. But as for the moment, we will accept it, and we will not proceed with any additional interventions at this time. Seems to be completely dry. There's no even a drop of blood there, so it's a very effective and reliable closure. Well, I believe the case is finished, so I can come up here closer to the camera. I can just thank everyone for joining, everyone who was watching. I hope the case was educational and useful. What we saw was Evolut R 34 millimeter valve in a big anatomy, a big calcified anatomy, deployed in a proper position. We ended up with more than mild, probably PVL, or mild plus PVL, which is probably due to the big anatomy combined with severe calcification. One could speculate if Evolut Pro Plus 34 would have been a choice which would have delivered maybe a slightly better result, but on the other hand, then you need a much bigger French size, puncture hole in the groin, which is to us a bit of a concern sometimes, is for this patient especially. That was the reason we chose Evolut R. Otherwise, you saw closure technique, you saw the procedure techniques we use, wire pacing on the LV, you saw the combination of ProStyle and angioseal in the groin, and for the rest, I believe we have a nice rhythm remaining. There's no pacemaker, there's no bleeding in the groin, there are no other complications. So kind of a nice case, except for slightly more than usual in terms of PVL. So from here, I will say goodbye. Thank you again for joining. Thanks to the team for making this case happen. And see you next time.